My name is Jacqueline Baith, and my presentation is over scaphoid avascular necrosis. Avascular necrosis is the death of bone tissue due to the lack of blood supply. This can lead to tiny breaks in the bone and then the bone's eventual collapse. This condition can be referred to as Preiser's disease or osteonecrosis. The anatomy of the scaphoid includes the tubercle, the capitate fossa, the waist, and the lunate fossa. The scaphoid has several different articulating surfaces. For example, the superior surface articulates with the lower end of the radius. The inferior surface is broken up into two parts, the lateral surface, which articulates with the trapezium, and the medial surface, which articulates with the trapezoid. The dorsal surface has several attachments for ligaments. The volar surface is attachment for the transverse carpal ligament and the origin of few fibers of the abductor pollicis brevis. The scaphoid bone lies at the radial border of the proximal carpal row. It is elongated in shape and placed obliquely. This allows for bridging and acts as a stabilizing rod between the two carpal rows. It is found on the floor of the anatomical snuff box. The anatomical snuff box is a triangular depression found on the lateral dorsal aspect of the hand. It is located at the level of the carpal bones and is best seen when the thumb is extended. The ulnar border of the anatomical snuff box is the tendon of the extensor pollicis longus. The radial border is the tendon of the extensor pollicis brevis and the abductor pollicis longus. The proximal border is the styloid process of the radius. The floor borders the scaphoid and trapezium, and the roof of the anatomical snuff box is the skin. The anatomical snuff box contains the radial artery, the superficial branch of the radial nerve, and the cephalic vein. The scaphoid bone receives blood supply from the branches of the radial artery. The inferior portion of the scaphoid is received from the dorsal branch, which supplies 70 to 80%. The superior portion of the scaphoid bone is the volar branch, which supplies 20 to 30%. There is no true mechanism of injuries for avascular necrosis, but is often secondary to other injuries, such as fractures. These signs and symptoms include pain, tenderness, stiffness of the wrist, decreased range of motion, a weakened hand grip, and crepitus. The diagnostic test for avascular necrosis includes an X-ray, a CT scan, an MRI, and a bone scan. The predisposing factors include joint or bone trauma, such as fractures, fatty deposits in blood vessels, sickle cell anemia, and Gaucher's disease, which is a buildup of fatty substances in certain organs. Risk factors include trauma, steroid use, excessive alcohol use, and radiation therapy. The differential diagnoses include osteoarthritis, inflammatory synovitis, complex regional pain syndrome, which is chronic arm pain that develops after surgery, a stroke, or a heart attack, soft tissue trauma, and osteomyelitis, which is a bone infection. Non-surgical treatment includes NSAIDs, cholesterol-lowering drugs, blood thinners, exercises, and electrical stimulation. Surgical treatment includes core decompression, bone transplant, bone reshaping, joint replacement, and regenerative medicine treatment. Refer the patient to a physician, and there should be no immobilization involved. Prevention of avascular necrosis includes limiting alcohol, keeping your cholesterol levels low, monitoring steroid use, and do not smoke. There are no Mulligan techniques for this condition. And here is my peacock, and then also my references, which then concludes my presentation. Thank you.